Good morning, everyone. Welcome to Medicine Grand Rounds. We'll just give a few minutes for people to join and we'll get started in a moment. So just give us a minute or two for people to join in. Good morning, everyone. We're just giving people a second to join in. The numbers are still climbing on the Zoom screen, so it'll take a second for it to get everybody in. Okay, let's get started. Good morning, everyone. Mark Crowther, Chair of the Department of Medicine. I apologize if there's background noise. I'm in a meeting, and secondarily, if I freeze, Leslie is poised to take over. I've got a poor internet connection. Today, we're pleased to have Dr. Parveen Wasi speak to us about accreditation, and I'll turn it over to Leslie in 1 second to introduce it. Just to say that this is the first of the Chair of Medicine Grand Rounds for this year. We'll have monthly Grand Rounds as per usual on the first or second Thursday of each month, and then return back to the usual hospital rounds. I know that Khaled and Madeline are planning some changes in the way that Medicine Grand Rounds are run. That will be announced over the next couple of weeks to try to simplify things for everybody. So without any further interruption on my part, I'll turn it over to Leslie, who will introduce Parveen, and we'll get going on today's topic.
Thanks, Mark. So it's my pleasure to introduce Dr. Parveen Wasi, who is, I'm sure, very well known to everybody in this crowd. She's a professor with the Department of Medicine within Hematology and Oncology practices at the Derwinski Hospital, and is the Associate Dean of our postgraduate medical education since 2016. Prior to that, she was the program director for the internal medicine residency program from 2000 to 2011. So she has a lot of experience both on the ground with accreditation, putting an individual program through accreditation, but also helping all across postgrad in preparing for our upcoming accreditation, and has been a wonderful resource to all of the program directors as well as all of the residents as we prepare for this. So I will hand it over to Dr. Wasi. Thanks so much for taking time to speak to this.
Thank you so much, Leslie. It's a pleasure to be here. I'm just going to put up my slides. I will try and I presumably I can share it. Okay, you can see it, Les? Okay. Thank you. I'm just going to start with a land acknowledgement. McMaster University recognizes and acknowledges that it is located on the traditional territories of the Mississauga and Haudenosaunee nations and within the lands protected by the Dish with One Spoon Wampum Agreement. So I'm going to talk about just really the general process for accreditation and kind of spend a bit of time at the end about, you know, the accreditation decisions that are made and why they are made. This can be, it's a bit, I can't really see how our questions are going to be asked. Leslie, how does that work on, because it doesn't happen on this?
No, we have the question and answers are open, and the chat should be open as well, Parveen. So
okay, perfect.
You can monitor for them, and then if there's something burning, certainly Leslie or I could interrupt as well.
That'd be great. So please feel free to interrupt me. I will consider it an interruption at any time. And sometimes these accreditation talks can be, I would say, a little bit dry. So, you know, any kind of question or comments are certainly welcome. So our last on-site review was April of 2015. And our next one is scheduled for Sunday. But the date's been changed around 3 times, but because of the pandemic. But our final week that we've landed on with the college is it starts on Sunday, which is usually a get together with the program directors, the chairs, and the division heads. And then the last day is Friday, where we kind of do exit meetings. The way that the survey is set up, there's an institutional review team, which is co-chaired by the college and CFPC, which is really looks at our affiliated hospital sites, looks at how the program, how PGME functions, support that it gives to programs, and also the support PGME receives from the university. And that is the institutional review team is actually the one that makes the institutional accreditation decision, which is actually new for us. The Royal College chair chairs the Royal College program review team, and CFPC gets a whole week of accreditation because they have a separate team for family medicine. For each of our programs, there's 2 surveyors and potentially a third in terms of a resident. There's only about 2 to 3 residents usually on an entire survey team for the college. So obviously they can't go to every program. So you may see one, or you may more likely you won't. The time allocated for surveys really dependent on the size of the program. So usually subspecialty programs would be about half a day, 3/4 maybe, for larger subspecialties, but for internal, it is a minimum of usually 2 days, sometimes 2.5 days. It depends on if they can get the meetings together. And that's just because of the number of residents, number of resident meetings, and the number of faculty meetings, and the number of sites that are involved in internal medicine. So my objectives for today is to describe the process of program accreditation, describe the accreditation decisions, and maybe touch on what the impact is on the program and the university. And then really very briefly, some strategies for success, which are really very, very brief and very superficial. And I think, as Mark said, this is the beginning of an accreditation year. And so Leslie and your subspecialty program directors will be meeting with all the faculty to review the process as it pertains specifically to their own program. So I'm going to start with CanEra. So this is something that a lot of you may see is it's for Canadian excellence in residency education. Accreditation went through a huge reform at the time that CBME was rolling out, so probably for 8 or 9 years. And in terms of looking at all of the aspects of accreditation, and the name change to CanEra, which really implies kind of a collaborative relationship between CMQ, the College of Family Physicians of Canada, as well as the Royal College. So what the highlights of this accreditation reform is new accreditation standards, which were rolled out in 2019. We were lucky with our timing because in some situations, institutions in the pilot part were actually accredited with the new standards, but having had done the internal reviews with the old standards. But we actually hit the right time so that all of our internal reviews use the new standards, as well as a digitized accreditation management system. New accreditation decisions, they're not that new, there's 1 or 2 that's different. And also the biggest thing, it's changed into an 8-year cycle instead of 6 years. And I think for us, probably for postgrad and McMaster University, is that there is an institution accreditation decision, which never existed before. So prior to that, we'd get a list of strengths, a list of weaknesses, and you'd have to fix them. But there was really no monitoring or accountability for fixing it. Now, you actually will get an accreditation decision for the institution that will require formal follow-up. There is also a focus on CQI for the program and for postgrad, and that actually makes a difference to the accreditation decisions. And then finally, a lot of this was predicated on CBD rolling out. So the language of the accreditation standards also reflect competence by design and traditional program streams. What is the purpose of it? So really, as in any accreditation process, including hospital accreditation, it's really a quality assurance. Are we having the minimum standards for residency education? But also, we're really trying to promote that accreditation is also about quality improvement, that this is an opportunity for us to improve all of our programs as well as our postgrad structures. It standardizes it across programs. And I think, what accreditation to me, and, I think people have said I've drunk the Kool-Aid of accreditation, but it really does standardize training across Canada. And it is one of the major reasons why Canadian residency training programs and the residency medical education is probably the best, one of the best in the world, because of the accreditation standards and the impetus of accreditation. The standards provide a blueprint for the program. And also, I think, I think this can be a bit of a double-edged sword, is the leverage for change. So for new initiatives, and unfortunately, sometimes what's happened is that anytime something new comes along, it's kind of, let's put it in the accreditation standards without making sure that there is appropriate resources for programs and for postgrad. We've certainly seen that. So CanMeds, it's very 2015. It was really CanMeds, really the impetus to actually put everything in CanMeds came from accreditation, and then competence by design. It's also a leverage for change in problems that you can't fix. And there's lots of things that it's very difficult for postgrad and for individual programs to fix. That's partly the reason, probably most of the reason why the institution now has a decision attached to it, is to say the stakes are a bit higher, so that if we need something fixed that might affect our accreditation decision, it actually may result in more action than if it's just basically a weakness that's identified. I think, I've always, as a program director, as postgrad dean, residency training, residency program, and I know Mark feels exactly the same, is really the jewel in the crown of the departments and the divisions. Everybody can get behind residency education because they get behind their residents. They're proud of their residency program, and everybody gets together and is vested in accreditation results. And I think actually this is actually really quite a positive. And also one of the things that, one of the future things is that it does promote best practices. The challenges of accreditation, and I think some of you who've gone through it, is the workload. It's not changed. One of the reasons for changing to a digital management system is that it's always there and you can always keep, but it is still quite a bit of work to compile that and to put that in for program resources. There's often insufficient resources during accreditation year because of the fact that resources don't change, they don't increase. The program director suddenly doesn't get more time. The PA suddenly doesn't get another half day to work on accreditation. It's on top of everything else. So, I think that sometimes we do, we may want to think together about how we can help our program director and our program admins. There's always the perception of inconsistent decisions, that one program got this and the other program got this for the same issue. It's a little bit less now with the standards because they're a bit more detailed. And definitely there's a sense that it's punitive. It's, we've heard the Royal College being called, it's a witch hunt. It is definitely, and also the word probation, despite the fact that we have really kind of tried to say it's not probation. As soon as a program gets put on notice, the message is across Canada that program is on probation. It's hard to change the messaging. I think one of the big things for the accreditation standards and for the Royal College to hear directly is the expectations on program directors. It's I was a program director a long time ago, and I see now what the accreditation standards were compared to what I had to be compliant with, and it's exponentially more. So every time you turn around, there's a new thing that program directors have to ensure. So it's a problem, and I think we need to recognize that it's a problem. The other big issue is that the program or the institution is held accountable for issues that are beyond their capacity to change. So we've seen, hospital structures, aging hospitals come up on institution reviews. Certainly, postgrad doesn't have the money to actually build a new hospital. So those things are actually a bit frustrating for people. I haven't been to a single accreditation visit at another institution when there wasn't a program that was surprised by the results, because there was something that came up in the resident report that actually the program didn't know about, or postgrad, same thing with postgrad. There is a perception that the college surveyors rely more on resident feedback, and there isn't an opportunity for closing of the loop. And then the consequences of accreditation decision. And if I could say one thing about accreditation, is the decision is for the betterment of the program. The decision, it's a team effort, residency education. It's not on the shoulders of a program director. It's everybody together. So whatever the decision is, we own it together. But however, it does result in a lot of stress and a lot of pressure, especially for program directors, post-grad deans as well, and the chairs of the department. So I'm just going to talk about the process itself. So the first thing that happens is that the program profile, which is actually the electronic PSQ, pre-survey questionnaire, gets filled out. So we have all the programs are working busily on filling it out. It goes to postgrad and we review it through our accreditation committee and just kind of see if there's any gaps that we need to get back to the program. In probably around February, we don't have the exact dates yet. The program profile is finalized by postgrad and sent to the college. The college will send it to the specialty committee, which is, internal medicine, specialty committee of gastro, et cetera, for comments. And then those comments will flit down to the program director. So they have them before the survey, which I think is actually nice. So you're not surprised at the comments. And then the comments, program profiles, and the specialty committee comments are sent to the surveyor. The survey process itself is scheduled over a week, as I just talked about. And again, we don't know the exact dates of individual program reviews. Hopefully we'll get them so you can, but we have asked people just to block the whole week, really from Monday to Thursday. We usually coordinate the visit with program directors and program administrators. One of the things that has happened over the last 2 years, as you probably know what I'm going to say, is that accreditation has turned virtual. So the last 3 that were done were virtual. There are advantages to the virtual format, but also some disadvantages. And so our hope is actually that the May one is going to be on site, but I think, as we all know, things may change. But the review of documentation like resident files, minutes of RPC, used to be on site. It will now be it will continue to be virtual. It will continue to be electronically through a secure system. And then they have meetings with stakeholders. After they do the program, there's an evening meeting with the entire Royal College Committee, and the surveyor, the primary and secondary surveyor, will report on the program and give their accreditation recommendation. That recommendation is discussed at the committee. They make a recommendation as a committee, which is conveyed to the program director and to the chair, division head. And then the report comes to the program, usually about 4 to 6 weeks later, and for the program to respond to any factual errors. Then the report and the recommendation goes to the residency accreditation committee. Because ours is in May, my expectation is that all of our programs will likely be reviewed at the fall October residency accreditation committee, and that's when we'll know what the decision is. Sometimes the residency accreditation committee will overturn a decision. Either way, they may take a program that's on APOR, change it to a regular, vice versa, or they may change an APOR program to an external review. Certainly external reviews changing to notice has happened at the residency accreditation. They're the ones that will make the final decision. The process, this is actually the process afterwards. And then we get a decision, but the time starts at the time of the decision of the survey. So if you have 2 years to fix something, it'll be starting in May, as opposed to the fall residency accreditation committee. So I'm just going to talk about, what is the surveyor looking for? What do they do? So I've already kind of said they get the program profile. They look at the weaknesses that are identified in 2015. I just want to make clear that the internal review that any of your programs have had do not go to the surveyor. They will go to the chair of the institution. And the reason for it is it's not reviewed to look at individual programs. It is reviewed to make sure that the internal review process of postgrad is robust. And so it's for quality improvement for that process. And then they look at the previous RC survey. All of this information is provided to the surveyors by the program director and the program assistant, including the minutes of the residency program committee, the competence committee, resident assessments, etc. So what the surveyors are trying to do is they look at the profile, which kind of outlines the program. Then what they will do is they will try and triangulate information. So they'll speak to the PD first, then they do speak to the chair, division head. Probably the most important meeting is the residents. And then they will meet with faculty. The faculty, it depends on the sites, and it's usually people that are heavily involved in residency education. And then the final meeting is actually with the residency program committee. So they're trying to look at things like, you know, how does remediation get handled? If a resident has an issue, how would that get handled? And they're trying to make sure that everybody kind of has the same idea of how issues are handled. So it's you know, part of the process of getting ready for accreditation is really information, and I'm sure your program directors will continue to supply the faculty with information and the residents about all of the program processes, because unless you're deep into it and doing it, sometimes it's hard to know. And I think, you know, over the next few months, usually I think starting January, it's probably a good idea to start kind of speaking with faculty about processes that the program uses. The meetings are with program director, division director, program admin. Residents are usually maximum of 20, and they're usually level specific. So you can imagine with 100 residents, that's multiple meetings, and they will be divided into PG1s, 2s, and 3s for internal. For subspecialties, it'll be R4s and R5s. Faculty, the residency program committee, and then there's an exit meeting the next morning, sometimes in the evening. So for faculty, I put faculty in there because I'm assuming most of you are faculty. I can't really see you. The general program info is, you know, what is the program's weaknesses previously, what's been done, what are you aware of what the program is facing, and how are you informed about program updates? Some of the questions that are asked of faculty is the resident assessment process. Always a little bit, maybe a little bit less straightforward than it was when it was just the ITER. But now with CBDs and EPAs, they're going to ask about that. Faculty evals. Do they receive do you receive evaluations? How often? How useful are they? Does someone debrief with you? Goals and objectives. Do you get them before your rotations? Are they used? So those are kind of, you know, I think Leslie and other program directors will go through some of these questions. We'll be sending out a file of all the questions. And these are the same questions we used at the internal review as well. I think one of the things is, are you valued as a teacher? Does McMaster University recognize your teaching contributions? And what's your relationship with the program director and the chair of the department or division chair? It's probably, you know, again, I don't want to, and I want to be factual and not in a coaching mode, but I think one thing that we do caution faculty about is, you know, to be frank, the college is not really, you know, that vested in your lives. But just really how it pertains to residency education. And I think we just need to kind of if the fact that you're so busy, it's really influencing the ability to supervise residents appropriately, or, you know, you're like basically kind of have inundated with assessment requests. Those are things that they are interested in hearing about, is really just how it's affecting residents and their education. So this is basically the categories of, I'm just going to stop there and see if there's any questions about that.
Parveen, there aren't any in the question and answer or in the chat. If anybody has a question and answer, or a question or a chat thing, you can feel free to enter it, and Leslie and I'll bring it to Parveen's attention as we go along.
Okay, great, thank you. What the how and why of the categories of accreditation. So they're coming here. They're going to be here for a week with us. At the end of it, I will hear about my I shouldn't say is the institutional decision. Programs will hear about I should also say recommendation of the recommendation. But how do they decide? So the standards are really what they decide on. There's really nothing else. It's the standards and compliance with the standards. So there is, in the new organization of standards, 5 domains. Program organization is really looking at the function of the program director, the support that the program director has in terms of time, remuneration, and administrative support. And they're looking at the function of the residency program committee. Are they making decisions? Is the climate good at the RPC for resident input? Is information about the program flowing to the rest of the faculty and to the rest of the residents? So that's kind of looking at what the infrastructure of the program is. The education program is the academic clinical curriculum and assessment. So it's everything has to do with residency education in terms of the curriculum part, and the assessment part they'll be looking at is both the traditional stream as well as competence by design. Resources, bit self-explanatory. Learners, teachers, and administrative personnel, or LTA for short, is really the focus is for everybody is the learning environment. Is safety, supervision, support, education for teachers and administrative personnel, feedback. And then the last one is continuous improvement of the program. How does the program get information about issues that need to be fixed, and how do they go about doing it? So the standards framework is based on those 5 big buckets, and within those you have 9 standards. Each standard, and I put the number in because again, it just really highlights how much work there is each standard is defined by requirements. So you have one standard, whatever it is, you have a certain number of requirements that actually say that, yes, you meet the standard. But each requirement is actually defined by indicators, and there's 139 indicators. If you miss any one of them, that means that you're not compliant with the requirement. So it's a bit, I'm going to just show you what it looks like. Here's the standard for a program organization. There's an appropriate organizational structure. The standards are really phrased as outcomes. Structure, leadership, and administrative personnel to effectively support the residency program, the teachers, and the residents. And the requirement is, the element is kind of like little buckets in between the big buckets, is that the program director is available to oversee and advance the residency program. That's the requirement. But in order to meet that requirement, all of these indicators, except for the exemplary one, all of these indicators need to be met. If you miss one indicator, let's say even if a requirement has 8 indicators and you miss 1 out of 8, that means you are not compliant with the requirement. And it's not, I say it like that because it'll come up as an area for improvement. But if you miss 1 out of 8, it's actually always better than missing 5 out of 8, right? That is taken into account in the final decision. So it's not as arbitrary, you miss 1 and so it does get taken into account. So meets is all indicators are met. If an indicator is not met, that requirement will be an area for improvement. One of the things we have found with the new accreditation standards and system is that every program is getting many AFIs, or areas for improvement. That is not a big deal. That is just your quality improvement. Whereas previously, weaknesses, programs would get 1 or 2, they may get 3, 4, 5, 6, 7 AFIs. And still have a regular review. Okay, so the next step is, once you figure out that your indicator's you're not compliant with that indicator, and hence you have an AFI, for that particular area for improvement, the next decision is, what is the follow-up? In certain cases, for areas for improvement, in many cases, it's like, yeah, you're not compliant, but you know what, we actually know that you have a very good CQI. We know this is actually not that important. It doesn't really affect residency education that much. So we're just gonna fix it before we come back in 8 years. That's an AFI RR. An AFI 2Y or 2-year is you need to tell us what you're doing in 2 years. And that really goes with the impact of the AFI on the program itself and how important that area for improvement is. But the other thing that it will do is the CQI process. So if internal medicine has an absolutely great CQI, they know that there's an issue here. They've already identified it. It may not be fixed, so it's still going to be an area for improvement, but they're well on the way and they have a plan to fix it that everybody knows about. A postgrad has a good internal review process. So they say, you know what? we don't really need to come back and do the whole thing again. All we'll do is we'll just ask the programs for a documentation that this has been fixed. Does that make sense? So it really just is, CQI is so important to document it as well, because if they don't see it documented, then it doesn't matter what you say. That's the other thing for accreditation is the sheer amount of documentation, but you know, really it will really help to document everything. And the other thing is that, you know, for an external, like having the whole thing repeated in 2 years, is the impact on the education environment as well as the persistence. If there's no CQI by the program, if the institution internal review process sucks, they're going to say, you know what, we can't trust them. It's really an entrustment decision, actually, is we can't trust them to fix this and just send us paper. We have to come back and look at it. Or it significantly affects the program, and that the college thinks that it should actually, someone else should come and see it. So these are the possible categories of accreditation. The only one that's really changed is APOR. So for an accredited program with follow-up at next regular on-site survey, which is 8 years away, 2031, I can't even fathom what that 2031 is going to look like. This is acceptable compliance with standards. You definitely, majority of programs will have AFI, but really programs doing really well, we'll see you back in 8 years. This one is the action plan outcomes report, is because there's an AFI 2Y in there. It's one or more significant deficiencies. And again, you know, I just want you to remember, significant is what we put down there. Significant is not, you know, it's open to interpretation, but that's what the committee, the college committee, is there for, to review it, because sometimes what one surveyor thinks is significant, other surveyors may say, you know what, that's not a big deal. But this is a documentation that goes back to the college. And this is something that postgrad will discuss with the program director as to the best type of documentation. And sometimes it is actually an internal review that we send back, and it's 2 years. External. Okay, so you need to follow up by an external. An external review is 2 surveyors will come back, and a resident, I think. The one surveyor may be from the discipline. So maybe from internal or one of the subspecialties. And this is for a significant area of improvement, which affects the overall quality of the program, which it's felt that it's best evaluated by external peer reviewers. So this is a persistent area requiring improvement. So if something doesn't get fixed from your last review, they can't really trust your CQI process because you haven't fixed it. The nature of the area of improvement may require a reviewer, and that is often it's usually for issues of service education, intimidation, harassment, mistreatment. Those are the kind of things that people say they should come, Or the other one is resources. There's a specific area that really the surveyors who are not from that specialty can't really tell, do you have enough? The residents are not getting the experience that they may want an external review to make sure that the residents are getting the experience. So this often comes up much more in surgical specialties than it does in internal medicine or in subspecialties. And then concerns with the program or institutional's oversight. So it could have gone to an APOR, but you have no CQI process and they can't trust you. So they come back in 2 years to review it. Notice of intent. It is still an accredited program on notice of intent. The residents in the program will still be credentialed for the training that they receive. That's often a question that residents have when a program goes on notice of intent, is what happens to me. They stay in the program, but what does happen is that a notice has to go to CARMS. So it has to appear on the CARMS site that this program is on notice of intent to withdraw accreditation, obviously a bit of an issue with recruitment. So this is major or continuing concerns which call into question the integrity of the residency program and the educational environment. And then it's a 2-year follow-up. Withdrawal of a residency training is another category. It will only happen after a program has gone to notice. So if a program is on notice, 2 years later, they haven't fixed anything, they're actually, that's withdrawing. You can't get a second notice. The program will be withdrawn. In the 11, 12, 10 years that I was on the accreditation committee at the college, there was one program that was withdrawn. One out of many, 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 many notices. And often one of the things that we always talked about is that it is amazing how notice of intent can galvanize action. And programs at the end of, I mean, I don't think any of us looking for a notice, but is that 2 years later, this can be the best program in Canada within that discipline because it really affects change. So what are some of the issues for external review and notice of intent? I've mentioned some of them. If it's a learning environment issue that affects more than one program, it'll actually come back and be an issue for the institution. So if I have an emergency room where the learning environment in the emergency room, there's mistreatment happening and it's affecting internal medicine residents, surgical residents, OB/GYN residents, that actually becomes an institutional issue. It will still appear on each of those program reports, but it will come back to McMaster, a PGME at McMaster University. There is definitely a reputational risk, but I do want to not overstate the reputational risk. I think we do talk about it. It's very short-lived. So, you know, once the program fixes itself, it's all back to normal. It is actually a very short, but certainly we've seen it hit the paper that this program is on probation, and that's usually the words that's used. But again, it is a major driver for change that is slow in coming. And I think, you know, one of the things to consider from my perspective, from any accreditation, is that if there's a major issue with the learning environment, you know, it really just comes down to you fix it now as much as you can, or you fix it post-accreditation with the notice. Those are the choice. That is actually a choice there because it will come up in accreditation. Inadequate supervision, safety. So, you know, I think we need to be responsive to residents saying they feel unsafe. Sometimes it's hard to, I know, I recognize sometimes it's hard to pick apart where that comes from. Things that, you know, like concrete things is faculty not responding to pages after hours for on-call residents. Learners working in situations that are above their level of training. So again, you know, if they're an R1 and they're being asked to do R2 duties or R3 duties, especially this usually comes up in situations where there isn't a hierarchy of learners, such as in CTU. There is a hierarchy. On call, there's a hierarchy for IM. Usually comes up when there's a sole learner. A volume of patients, you know, if a faculty member has 40 patients, they obviously can't supervise closely as much as they would want to. That can sometimes lead to problems, and then faculty with competing clinical responsibilities. Culture of mistreatment, that will definitely hit a notice. If it's not been, now remember, I just want to say that no program is perfect. And there's actually no program, especially large programs with a lot of patient volume, that there isn't some issues arising. I think what they're looking for is not a perfect program, definitely. They're not looking for no problems. What they're looking for is your ability to know what the problem is, and your ability to get the support as a faculty, as a program director, to fix it, to help to fix it. Even if it requires more resources, more money, etc., that you have a plan in place. So the culture of mistreatment could be the faculty, and there's no consistent mechanism to address it if that's an issue. But again, if there's a mechanism to address it, it's been addressed. I think that actually becomes a bit of a kudos for the program, that they have dealt with it, and they've dealt with it effectively. Area specific, so this could be EROR, maybe due to interprofessional relationships. This is most likely to affect the institutional accreditation. Is that no voice of the residents? So residents don't feel heard. They just say stuff. They don't feel like anybody's listening to anything, and decisions are being made without input. Service education. Service education is a big problem for internal medicine across the country, for general surgery across the country. It's very difficult to define what is it, because obviously service, and I really hate the word service, but unfortunately I can't find a different word, because there is always learning in patient care. This actually probably where most of the learning happens, is actually during patient care, and we all recognize that, but how much is too much? And then, so things that are discernible is if someone has the call pager during academic half day and they're being called. They have to go back after academic half day and see patients after 5 o'clock because those are kind of very concrete examples of where this will come up. Okay, where it comes up in too many patients is safety supervision. And then lack of structure of the program, which I don't think is an issue for any of our programs in the Department of Medicine. So I'm going to stop there for a second, because usually this is the place where there may be questions about the accreditation categories.
Parveen, there's no questions in the question and answer or in the chat function. If anybody wants to ask a question verbally, if you can just put your hand up, I can turn on your mic.
Okay, all righty. Let's move on then. So what do we do to prepare for a survey? So this is one, right? So this is great that Mark and Leslie are asked to have a talk to faculty. This is like the beginning of kind of a lot of sessions. I think, we want to just engage the faculty in the process. Faculty are incredibly important to the success of a program. I'm just saying that it really is crucial to a success of a program. And I think, the more information the faculty have about the process and about what the program is doing and the program function, it's actually going to help us. The residency program committee, residents, and program admin. I really think communication is so important, right? Is what's the program doing? What's the issues? What are they doing to correct it? And what is the pulse of the program? And, part of the accreditation surprises that happen is people think the residents are really happy, and what happens is they're not. There's something that is really, and the atmosphere in the program is not enough for the residents to speak up. Again, I really, having seen all the internal reviews, this is definitely not the case in the Department of Medicine, but I think that is something that, you want to kind of keep track of by having regular town halls with the residents. The internal reviews will be very helpful. Surveys are helpful. And then document your CQI process, right? What are you doing kind of document all of the pieces of information you have, where it's coming in, what you're going to do about it, so that you have it ready to show to the surveyors. But remember, it's a functional document for you to use as well for a program. So the first step, I think, is really at the residency program committees to go through the standards one by one, make sure we're all compliant with it. Make sure that we let the residents know what we're doing. Sometimes in certain situations, we are actually can't tell everything to residents, especially when it involves faculty, because they are entitled to the same amount of confidentiality as we give to residents. So sometimes the residents feel like, nothing's happening. And I've mentioned this might be good to say something is happening. We can't really share it. This is our process, and this is what we do. I think, one of the things that it's useful, and I think Leslie has pointed this out before, is just to have the residents know what happens with VAC evals. And how we deal with them, because sometimes there is a little bit of a thing is that they fill out a whole bunch of evals, but nothing happens. But there is certainly a process. This is really just to avoid surprises. You know what, it's just you're able to kind of know these are my issues. And I think it's also upfront to make it upfront. It's a bit of a balance. You don't want to focus too much on things going, because you don't want the whole survey team just to go on that. But you want to let them know, yep, this is an issue. We're aware of it. Here's what we're doing, and frame it in that respect, right? So that will actually again demonstrate, yep, they do know, and this is a program that knows what they're doing. They have a plan. So the CQI stuff really is just to, and I know again the programs in the Department of Medicine are doing this very well. Lastly, it's an opportunity for you to, this is kind of show what's happening in the program, what's innovative in the program, showcase the caliber of our residents and our faculty in the Department of Medicine, in our programs, residency across the departments at McMaster University. Definitely, I use this to showcase the hard work of the program director and program administrator, not just leading up to accreditation, but throughout. It's, again, I can't emphasize enough that being a program director these days and a program administrator, with the number of standards, the number of issues, the number of things, let's add the pandemic on top of that, competence by design on top of that, it really is a very, very huge task. And I just want to say thank you to all of them. Leslie, I see, I'm sure there may be others in the room for the work that you guys do. Accreditation is a team effort. It really is. It's everybody coming together saying, you know what, the residency program is important to us, and we are proud of it. And I think all of you feel that way. I know that is, we're proud of our residency program. We're proud of our residents. We're proud of our faculty. It is, despite, the accreditation decision, it is still a CQI process. And I really fervently believe that it does lead to better residency education. It's a pain. It's a lot of work. It's a lot of stress. And, I feel it as well. But ultimately, I think this process is actually why our education system in Canada is so good. I really believe that. And that's all I have.
Thanks, Parveen.
That was useful.
Yeah, that was great, and a great summary. I'm gonna leave my camera off just because I've got a bandwidth problem where I am, and people don't need to see me. Thanks for a great talk and a very thorough presentation. Just if anybody has questions, please enter them into the chat function or the question and answer function, and we'll get to them. Or if you want to ask a question verbally, you can put your hand up and I'll give you the microphone. In the meantime, I do have one to get kicked off. So I think, Parveen, you and I have talked about this. What's the spirit across Canada, particularly internal medicine programs, just so that everybody sets their expectations correctly?
So internal medicine is going, internal medicine has always had waves of badness, right? So when I was a PD, there was like a whole bunch of internal medicine programs that went on notice or an external, either one of those. We're currently on a second wave here. Is that the last 4 have gone on unnoticed. One of them has actually not been reviewed at the residency accreditation committee yet. So the biggest issues have been that I know of is mistreatment in one, service education, and supervision. exactly what we've said is that, the volume, I think internal medicine program has been especially hit by COVID. Because a lot of the workload of patients caring for patients with COVID has fallen on internal medicine and hence internal medicine residents, and also CBD. I think whether the competence by design has actually put a big strain on faculty and also on residents, and especially the morale of residents trying to get EPAs completed, etc., has really across the board affected internal medicine. And again, I think the faculty are stretched. I think anytime faculty are stretched, that it invariably, no matter all of our efforts to protect our residents, it does fall sometimes on how we supervise and how we engage with our residents, how free we are to teach. So, I think there is I think we want to go through into this, and this is, is we prepare for it, and we hope for the best. I think what we need to recognize is internal medicine at MAC, and certainly under Lori's leadership and under Leslie's leadership and Sherrick before them, the infrastructure of internal medicine, the sheer amount of education, the sheer amount of talented faculty, the sheer amount of research opportunities, other opportunities, EDI, internal medicine has always been ahead. I would say the two programs that are always leading the way for postgrad, actually for me, is internal medicine and family. So I think we need to kind of remember that. There's lots of things happening around us, but we have to remember that our core, our foundation is actually very strong. And that's not always the case across the country. So I think we're hoping for the best. If it goes unnoticed, it's not from the lack of trying. It's not from the lack of really trying to make sure, and maybe things will be better. But I think people are already trying, and I think there is a plan to going forward to help with some of the issues that may be a threat to us. COVID, even if we don't really have that much COVID anymore, I'm not really sure because I don't have any numbers, it's just generally caused a huge morale issue, and that permeates into the rest of the program for residents and for faculty, and it's hard to be very exacting in terms of how much of an influence it has, because it's very kind of ephemeral, right? You just don't feel like it's just the life itself is has been a bit altered by it. So I'm very hopeful, and I think it's in good hands with you, and in good hands with Leslie and with the faculty. I think the residents are actually quite loyal to the program as well, which actually makes a difference.
Thanks, Parveen. I'll just say that, general internal medicine will be one of our foci across the next year, but this is going to consume an awful lot of bandwidth in the department across both the direct entry programs, of which we have 4 in the department, as well as our subspecialty programs, of which we have many. And so please, everybody who's watching this, be prepared for a little bit of work this year, but also some education that you'll be asked to attend meetings. Please ensure that you do so, because as Parveen pointed out during the talk, you may well be asked questions somewhat off the cuff, and an incorrect sort of off the cuff answer that you provide could actually have a negative impact on the accreditation, particularly around do you get evaluations, and also are you doing evaluations of the various learners that come through your clinics and your inpatient services. So please be aware that those meetings will be called and that you'll be asked to attend them. Leslie, do you have any questions to ask? We still don't have any questions in the chat box or in the question and answer. So Leslie?
I don't have any specific questions, but I just want to say thank you, Parveen, for taking the time to do this important summary. It's been a long time since anyone has gone through a formal accreditation survey. Everyone here has probably been through an internal review in the last few years, except our new PGY1 learners, and we have a number of them. But beyond that, everybody's at least participated in the internal review process, of which mirrors very nicely what they'll be going through with accreditation. And I think that's very helpful. And I know it's a huge amount of work that postgrad puts into those internal reviews. So thanks for today, but also for all the work that you do to kind of make sure everybody's prepared for what this will look like.
Thank you, Leslie.
Dr. Mitri says, thank you for an informative session. And I'll say congratulations to Dr. Mitri on his new arrival that I saw posted on one of the social media venues that I very rarely look at. And Parveen also said thanks to Parveen for a great sit around. So if there's any last questions? Nothing's been posted. So with that, maybe Parveen, I'll just say thank you for an excellent set of rounds, and we'll look forward, the audience should look forward to lots more information about this over the next year, and we'll all breathe an enormous sigh of relief just as next summer is firing up and accreditation is receding into the background for all of us. So thanks very much, Leslie and Parveen and all the program directors and everyone else. Leslie, last word? I
just see there's a hand up actually from Punji.
Okay, oh, there we go. Just 1 second, I'll open. Okay, Punji, you should have an open mic. You have to unmute yourself.
About that. Can you hear me?
Yes, we can.
So firstly, I want to thank Parveen for an excellent sort of talk and giving us a background to this. For me, it's a very complicated system, and I commend you all for having to put all this together and really make it a wonderful residency program. I must admit there are some gaps that I find on a day-to-day basis, which I think it'd be good if, maybe Leslie and our group in the different centers meet from time to time to discuss some of these issues, because I think we could still make it a better program. And my concern is mainly on the clinical assessment and on the abilities of residents to use Bayesian principles in the clinical assessment and management of patients. And I really think that it could also, because many times, when a resident presents a patient, there's a whole barrage of sort of investigations being done. And sometimes when I ask them, why did you do an investigation? Well, they say, well, we just want to make sure and just cover it. But that, to my knowledge and experience, is not based on Bayesian principles. I think we need to inculcate that into the program, into the teaching of our residents, and just to make them better clinicians. I think, maybe Leslie, for you, if we have the opportunity to meet with you sometime as a group, I think that would be great, so that we, at least on an individual basis, we can tell you some of our concerns and maybe ask, maybe your advice and other people's advice and how we can fix it, And I think it's a great program, but I think we can make it better. Thank you.
Thank you. Leslie, a quick response to that, just watching the clock.
Yeah, thanks, Punji. And I think, maybe in the coming few months, I can set aside some specific time to sit with the faculty from each site. I do attend, generally speaking, the GIM meetings at all the sites, but you're right, this probably needs dedicated time to sit and talk about outside of a meeting where the agenda is already usually quite packed. So I'll certainly look to set some of those things up. Thanks so much.
Thank you.
All right, with that then, thanks everybody for attending and for careful attention for an hour. And thanks to Parveen for a really clear, comprehensive presentation that undoubtedly everyone will have the opportunity to see again next year, just as a reminder. So thanks everybody. We'll see you in a month and in a week for regular grand rounds. Thanks very much.
Thank you, everybody.
Thank you.